So first of all, my name is Anna Duncan, and my pronouns are she, her, hers, and I will be kind of the moderator for today's webinar entitled Best Practices in Integrated Pediatric Mental Health Care, which is part one of our three-part series. And I think if, Maggie, if you want to go to the next slide, we'll start with the land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. Within Seattle and where we are located, we acknowledge the Coast Salish peoples of this land in Seattle, indicated in the purple, the land which touches the shared waters of all tribes and bands within the Duwamish, the gray and black, Puyallup, Squamish in blue, Tulalip and Muckleshoot, which are in yellow, nations. As we move forward in advocating for and moving toward health and racial equity, let us remember that we are living in a history-driven present. Let us learn more about the histories, cultures, and traditions of Indigenous peoples and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult nativeland.ca to learn more. And we can go to the next slide. Thank you. So before we begin, I'd like to do some Zoom housekeeping. So if you encounter any technical issues during this webinar, please send us a message through the chat box, which is highlighted in red. We will also have a question and answer session after the presentations. So if you have a content related question, please send it using the Q&A function, which is highlighted in purple. And please note that all content related questions will be answered after the main presentation. So we'll try to get to all of those at the end. It's also really helpful. Our presentation will be from multiple presenters. And so if you have a specific question for one presenter, it's really helpful if you can specify who it's for. During the Q&A, you can also use the raise hand function as well to ask a question verbally. And as an additional reminder, we will be recording this webinar and it will be uploaded to our website. I also wanted to say that as a reminder, this webinar series is approved as a CME credit provider. For more information on this process or to receive a certificate of completion for CME credit, please contact us at our general CoLab email, which is uwcolab@gmail.com. You don't have to attend all 3 webinars to receive credit. They can be done in an a la carte fashion. However, we do, of course, we would ideally love to see you at all 3, and you can attend 1, 2, or all of them and get different amounts of credit. And as I mentioned before, all of our webinars will be recorded and uploaded, and CME credits can be received by watching them retroactively. At the end of the webinar, we'll send an evaluation survey link through the Zoom chat, and you should also get that the survey link emailed to you as well. So we would really appreciate if you could fill it out with any feedback you have so we can improve future webinars. We'll also send out a link to the recording as well, so it will be really easy for you to access. And we can skip over this one because we already reviewed the poll. And then I'm just going to kind of provide a brief introduction to this webinar, who CoLab is and who our presenters are, and then I'll hand it over to Elizabeth and Larry. So again, I want to thank you all so much for being here. We at the CoLab for Community and Behavioral Health Policy are really excited to host this webinar series and to have you here today. Today's webinar is the first of a 3-part series focused on pediatric integrated care and what we can learn from this exciting healthcare model. The second webinar in the series will take place next Friday, November 19th, and the final webinar installment will take place on Friday, December 3rd. And we would love to see you back for those. And again, you can always watch them retroactively if need be. For those of you who are joining us for the first time, the CoLab for Community and Behavioral Health Policy was founded in 2020 within the Department of Psychiatry and Behavioral Health Sciences at UW School of Medicine. The CoLab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly those involving youth and families. We believe communities and systems have deep knowledge and expertise that must be leveraged to promote effective, sustainable, and impactful community programs and strategies. If you're interested in watching other webinars we've hosted or learning more about our work, please visit our website at uwcolab.org. For today's webinar, we're really excited to have two wonderful speakers, Dr. Elizabeth McCauley and Dr. Lawrence Wissow. I'll let them tell you more about themselves, but briefly, Dr. McCauley is the Associate Director of the Child and Adolescent Psychiatry and Behavioral Medicine at Seattle Children's Hospital, and Dr. Wissow is the Director. And without further ado, I will hand it over to them. Thank you so much.
All right, I think I get to go first. I'm Larry. Elizabeth and I are actually right across the hall from each other at the moment. But in this marvelous world of COVID, we're going to be speaking in taking turns. I thank you all for coming. I just have to say one thing that reflects my age. Whenever I hear somebody say, "Oh, you can watch it retrospectively," I think, "Oh, you can play it backwards." And I think of the Beatles album Abbey Road and the idea that I can't remember which of the tracks on it that if you played backwards, it supposedly said that Paul was dead. So if any of you get to listen to our webinar today and you choose to listen to it backwards, let us know if there are any hidden messages that come through. Anyway, having just destroyed my credibility and revealed my age, I'm Larry Wissow. I'm a child psychiatrist. I have the pleasure of working with Elizabeth and a lot of other folks here at Seattle Children's and also in the division of child and adolescent psychiatry at UW. And we're going to talk about integrated care as just the very beginnings of what's I think will be a very nice three-part series. And my job first is to try to give you a little bit of background. So go to the next slide, please. Our learning objectives for today are to identify some elements of commonly used, integrated care models, understand how mental health interventions can be re-engineered to be more compatible with the structure and process of primary care, and to identify some emerging challenges to the delivery of mental health in primary care practice, especially children's. And neither of us have disclosures, and both of us are very grateful to folks that have funded our work over time, and to many colleagues whose ideas we're going to be fronting for today. Next one. So I just want to start out by saying, and I say this more and more the older I get, that there are many of the ideas that we are still trying to implement today, and that we try to that we kind of discover and rediscover over time, but that this idea of integrated care in some ways is coming up on 100 years old. That in the 1930s, especially in the United Kingdom, the idea of within the National Health Service of having first contact access to care in a primary care setting that would be happening over a long time, be very person focused, be very comprehensive, coordinate with specialty care, that this idea was really something that was talked about and people tried to bake into the system. And then in the 1960s, and this was something that really came a lot out of pediatrics in the US, was this idea of a medical home. And the quote here from HRSA is a cultivated partnership between the patient, the family, the primary care provider, in cooperation with specialists. And obviously this isn't limited to mental health care, but very much in the spirit of trying to care for people holistically in the context of their families, and being a place where all these various sorts of things are sort of put together in a coherent way so that a family can access them and benefit maximally from them. Next slide. One of the core pieces of all of this has been this concept of task shifting. So we're going to walk through a few different terms that have overlapping significance for this work. So in task shifting, we're thinking a lot about moving some particular medical task from a more specialized person to somebody who's less specialized. And I want to say very strongly that the level of specialization says absolutely nothing about level of expertise. Sometimes these things do correspond to hierarchies in our system, but they don't necessarily have to be. And there's definitely much more. There's very great variation in kinds of knowledge, and in general, in many of our settings, it's the less specialized workers who have the most local knowledge and the deepest connections with the patients and with communities. So we can think of this spectrum of from specialty to less specialty as really going in multiple sorts of directions. But the main idea is that we've got something that, in this particular case, a psychiatrist or psychologist at a doctoral level knows how to do, and they're passing this on to somebody who was not primarily trained to do that, and importantly has to learn how to do it in a potentially very different kind of setting than the one in which the specialist would be working, and possibly with a very different population. So task shifting is this one concept we want to sort of keep in mind, because that's been a core of all of the collaborative care and integrated care models we're going to talk about. So next one. A lot of this work is built on something that Ed Wagner originally wrote about. I'm sure there was somebody who wrote about before, but he's the person who is most identified with the so-called chronic care model. And the chronic care model said that in primary care, what we're going to do is we're going to identify people who potentially have long-term needs, and especially long-term needs that might not necessarily be obvious to us, either because patients don't disclose them or because as healthcare providers, we're not looking for them. And the chronic care model had these four main components. So one was systematic case finding for some important condition. So for us, that's children's mental health problems and screening. Evidence-based interventions that were available at all points of contact, and in particular in primary care. So some kind of a way for a generalist primary care provider to be able to have at least enough expert knowledge to be able to implement state-of-the-art care. Then there's systematic monitoring. So what kind of processes do we need to be able to do to track people and make sure that they are not lost to follow-up? And then stepped interventions. So these are things that can say, well, if I'm going to try to do something in primary care, I'm going to track somebody. If it doesn't work, how do I move people on to the next level that's needed? Okay, next one. So collaborative care is something that really grew out of the chronic care model. And this is a term that's often used synonymously with integrated care. They're, in many people's parlance, the same thing. But when we talk about the collaborative care model, especially as it's been developed here at UW from the AIMS Center, the components are this assessment for level of care needed. So this is the sort of the screening, then delivery of care in a generalist setting, being reviewed and monitored by a specialist. So this is putting people into registries, having a way to track their progress, having an opportunity for the generalist to periodically sit down with an expert to say who's making progress, who is not making progress, and what else should I do. The possibility that care can be intensified as needed, something that might happen in primary care or might have to need a consultation from the specialist or transfer to somebody else. And then finally, really the core piece of this, that we've got this other collaborator, and that's the patient. So there's a big emphasis on engagement in care and having the patient be activated, engaged, and helping to guide their own care. Next one. There are lots of ways that people have then defined integration. The agency for the AHRQ has said that this is unifying care. So there's coordination and communication among providers to meet both mental health and general health needs. AHRQ talks about how this integration needs to happen at multiple levels. You know, the system has to come together, but then for any individual patient, we want the care to be coordinated. Over time, we've really added, you know, other things. So in terms of mental health, we've talked a lot about wanting to include mental health promotion as well as mental illness detection and treatment. We've wanted to sort of integrate the integration. So to recognize that what we're doing to integrate mental health has to really fit in with other things we're doing. And for pediatrics in particular, that means how does our integration of mental health really overlap with and ultimately be a seamless part of our integration around the developmental services in particular, and our care for kids with chronic health problems, somatic health problems. And finally, there's really been a realization, or I mean, it's always been there, but more and more discussion about how we integrate adult and child services. So coming back to that original 1930s, 1960s set of definitions, that even though we're in pediatric practices or in child mental health settings, that we are being truly family focused. And when we identify kids whose caregivers also have mental health problems, that we help them address them as well. Next one. Another topic, word that you'll hear a lot is co-location. So this is the idea that we've got physically present mental health and primary care in the same offices. And there are a lot of potential advantages to this. There's reduced stigma. You're not going into a door that says, here's the mental health care. You're going into a place that you've gone before for everything from well visits to rashes. There's potential for rapid access. Somebody's right down the hall. There are opportunities for informal consultation between the mental health and the primary care providers, just because they're going to see each other. And there's an opportunity for warm handoffs. I can at least introduce you now to the mental health provider. There are some risks or downsides to this. And the single biggest one is that having two people on the same hallway doesn't necessarily guarantee that they're going to collaborate or integrate. And that if both the primary care providers and the mental health providers just sort of stick to their usual models of care, that basically it ends up being no better than if they were on the other side of town, because the mental health provider will simply have their agenda filled up within, you know, a matter of weeks, and at that point the access issues will still be difficult. Okay, next one. So I'm not going to spend much time on this, but just to say that back sort of at the dawn of this more modern era of talking about collaborative care and integrated care, people spent a lot of time sort of thinking about, well, what are some of the just sort of systemic sorts of things that one might need to do to try to assure integration or collaboration, and talked about whether, you know, you should be in the same organization or not, should you be in the same place, how much should you share your record keeping and your scheduling, how should you do team meetings, how should you communicate with each other. So we can go to the next slide, please. And there's some good news and bad news about that. This is, you know, now a set of studies that took place, you know, quite a while ago, but there's still reason to believe that these conclusions are are sound. So what this slide looks at is a review of a number of studies from the adult literature looking at the treatment of depression in coordinated care, integrated care, collaborative care arrangements. And they're ranked from top to bottom by how many of those factors on the previous slide and other things, kind of how many of those boxes were ticked off. Were these very highly integrated systems where the mental health and primary care people were, at least on paper, working very closely together, or actually, did they actually not tick off too many of those boxes? And what's really interesting is that many of these studies were done by the same folks. And the take-home message here is that the little bars with the dots are either on that middle line or all to the right. So there could be publication bias going on here because it's very hard to get studies, published where you don't have good results. But the thing that the authors of this review pointed out is that there didn't seem to be a strong relationship between how many of those integration boxes got ticked off and how well the patients did. So the question is, well, if that's not what makes integration work, what does? So go to the next one, please. So this is at least my sort of list of at least some of the things that are needed. It's clear that underneath all of this, and all of you know this, if you've worked on medical home transformations and other things, that there's certainly a tremendous amount of actual systems work that does need to be done. But the thought is that that's probably necessary, but not sufficient. So one of the things that, what is it that we know about this? So one is that all stakeholders are important and need to participate in planning these integrated moves. And in particular, patients and families and non-clinical staff who have to both set up these systems, but who also interact with families in very important ways. And when we put that stuff together, then we get this mental health friendly environment, especially one that knows how to respond to patients' needs, especially when those needs change rapidly, or when people come in, frankly, in a bad mood, and we need to be able to respond to them in healing ways. Also, that we have to figure out how we're going to essentially teach people that this is now part of what we do, because there are generations of expectations that, in fact, we won't be talking about mental health in these contexts. And we have to, or people have been involved in mental health care in other contexts, and it's not going to be exactly the same with us. Next one. Ultimately, the other thing, and other things that we have to have are really trusting personal relationships between generalists and specialists. This dates us a little bit, but there have been a couple of studies, some of them looked at more things more qualitatively, and said that, well, one of the most important things about generalist specialist relationships was knowing somebody's phone number. So the fact that I can actually understand how you do your work, you understand how I do my work, and we can get in touch with each other. We have systems for working together, but actually we can humanize those systems. We have some effective way of record sharing. We know that that's the bane of every primary care provider's existence, of trying to get information from the black box of the mental health care provider. And then consistent mechanisms for case detection and tracking, so that the whole process is very systematic and very data-driven. Next one. So if we put this another way, because I'm starting to sort of wind up and get ready to pass this over to Elizabeth, that if you will, the climate and culture of the primary care site where we're trying to do our integrated health matter a lot. We have to recognize that mental health promotion and treatment really start at the first contact with the practice, and they involve everybody. That there are some core universal interventions that can target both parents and kids. And that's what we're going to sort of talk about next. On top of those, we can layer some targeted brief interventions. Having personal links to specialty care is really important. So really building up our network of people that we work with, and that tracking and quality improvement efforts are vital, just the same way as they would be for anything else. Next one. Okay, so I think there we go. Elizabeth, it's all yours.
So I'm going to jump in for a while. This is Elizabeth McCauley, and I'm going to talk a little bit building on what Larry has already presented, and kind of in anticipation for those of you that can participate in other presentations in this series. You'll get some more practical examples in some of the other presentations. I'm going to talk a little bit about how do we do this crosswalk from traditional mental health as we have known it for a long time, to kind of integrating mental health into primary care. And as Larry points out, this is something that's been, people have been working on for some time, tried in many different ways, and I think have had some success. And we know, given the emerging mental health needs in our communities, that we need to kind of push this even farther and make it more commonplace. So there are some mental health strategies that need to be shaped a little bit to fit primary care needs. I think if we go from traditional mental health, and we'll talk about that in a minute, it's a much more intensive, long-term kind of intervention strategy, and can be very involved in terms of what kind of evaluations are involved. So we want to be thinking about how can we rethink evaluation techniques so that we can fit those more effectively into a primary care setting, how we can think about what are the common element strategies for the top pediatric behavioral concerns, so we can support both primary care providers and integrated mental health providers to be able to make a difference, to move things forward in that setting. So if we could go to the next slide. Let's just think a minute about we are trying in some ways to fit a square into a round opening here, because if you think about primary care, high volume, short visits, continuity of treatments needing serial visits. So we do know that many kids are seen periodically, but they're not seen in the kind of cadence that we typically see kids in a mental health setting, where we're seeing them weekly for a while to carry out an intervention program. We might, in primary care, it might be every 3 months, it might be every 6 months, it might be annually. However, in primary care, I think something that is just such a wonderful and rich element is the long-term relationships with multiple episodes. So if you're in that setting, you can connect with a family, with a small child, provide some support, reconnect perhaps as that child might be developing some issues or around school attendance, reconnect when that's an adolescent who may have different needs. So also in a primary care setting, there's a very wide range of goals. So obviously the key goal is to keep people healthy, manage any ongoing medical concerns they have, but also foster their mental health. In an evidence-based mental health care, we have longer visits. Most visits are 60 minutes. We have, as I've said, extended series of visits. So many of the evidence-based interventions for child mental health problems have 12, 14, 16 sessions, some even longer. On a regular basis every week, 60 minutes a session, if not longer. So that would be hard to manage in a primary care setting. Then most patients, most kids, most families in a mental health setting are discharged after an episode of care, that we don't necessarily have the wealth of this long-term relationship. And I think these are some things that are actually being revisited away as we think about booster sessions and follow-up sessions in mental health. And then also in mental health, we're also often very focused on a particular goal. So we're not taking this wide range of goals. We're really focusing on depression, anxiety, a behavioral problem. So we're very focused on specific goals. So if we can go to the next slide, let's talk about some things that might help us integrate what may seem like two very separate worlds into one. First of all, there are some changes that have been happening in the mental health world that have developed out of the need to increase access to care and to enhance efficacy. And these are strategies that offer a little bit better fit with the integrated primary care setting. Some of those very much overlap with the things that Larry talked about in the collaborative care and the integrated care models that have been around for a while. So one is use of standardized assessment tools to inform treatment goals. And I think many, if not all, of the integrated care programs are moving towards having some kind of a standardized use of a standardized assessment for mental health problems as well as other health concerns, to be able to identify folks in need of care and to also inform intervention goals. The other thing that's happening, and this isn't, I saw that a lot of you were mental health folks, so this might not be how you were trained or consistent with your current practice, which might be more focused on a really in-depth multi-session evaluation of family history and related problems, and then moving into identifying a treatment plan. And where in many cases, there's a push in mental health because of the need for access, to increase access, to look at a different approach, which is the top problems approach. And that's an approach that allows for idiographic assessment of the top needs as a method for establishing intervention goals. So it relies a little bit less on extensive history taking, with the understanding, I think, that all clinicians have, that over time, as we get to know our families, as we get to know our patients, important issues will emerge that may shape or change what we're doing. But right now we need to get going. We need to take advantage of the time that we have. So then the next issue is setting specific short-term treatment goals with a time plan and a treatment contract in place. Now, treatment contract sounds a little off-putting, but it just really means realizing, I think there is a more attention across mental health settings, and certainly fits with integrated primary care, that we are probably going to be able to provide very few people with long-term weekly mental health intervention. That what we need to do is identify a goal that we want to work towards, work with the patient, the family to address that goal, and then think about what might happen next, or take a break from any intervention and check up with them at a later time to see if more intervention is needed. So coming back, the next thing is to come back to this use of assessment and use of both standardized and individualized assessment tools to monitor progress and direct the course of treatment. So just being a little bit more attentive to what are we working towards? Are we getting there? If we're not getting there, what do we need to do differently? What do we need to add? What do we need to subtract to be able to move towards the goal that we've agreed with? And when I say a goal, that's a goal that we've agreed with our family, with the patient, with the youth, that's what we have agreed to work on, that they're on board with that, and that we as a therapist are helping them work with that, the mental health person or the primary care provider. And the other thing that's happening, gotten great attention in child mental health, child and adolescent mental health, is the use of the common elements intervention approach. And we'll talk a little bit more about that as we think about how these things can be applied to the primary care setting. So if we could go to the next slide. So just to talk a little bit more very concretely about how does this assessment and case conceptualization, how do these changes, how could they be integrated into a primary care setting? So use of standardized assessments, we've talked about. Brief functional assessment, I'll talk about it in a minute. using how we do this top problems, also a walkthrough, and then thinking about setting a treatment, our goal, our target. So if we could jump to the next slide. So incorporating the assessments, sound a little bit like a broken record on that, but we feel like it's really critical that we're thinking carefully about what's informing our decision on a goal, what's informing a parent, our patient's, an adolescent or a child's understanding of what the needs are, what they want to work on, and that our formal assessments, standardized assessments, the PHQ-9 for depression, the GAD-7 or scared for anxiety, the SDQ, which is a larger scale for attention or conduct problems, assessment of an organized, standardized assessment of trauma, helps us identify with the patient what we're seeing, what we're concerned about, seeing if they agree with that. It's always important to see, do they agree? Is that what they put on the questionnaire? Is that how they're feeling now? And then helping us partner with them in making a treatment goal. And then just some examples of individualized things that you might use as you're moving forward and you're doing a brief intervention in a primary care setting. Individualized assessments can be number of days that the patient's able to get to school on time, or number of the days they get into bed by 11 p.m., or not for a parent, number of positive comments on their child's behavior they were able to make. So again, practical kinds of steps forward, just incorporating that into the practice so it gives people a little bit of concrete feedback. If we could go to the next slide. And then this is a bit of a, I think sometimes a more controversial topic, and it's the issue of revisiting evaluation. And many mental health professionals have been trained to do very in-depth mental health evaluations, lots of family history, lots of time spent getting in-depth history and also developing a sense of rapport with a patient or client or family. And I think that people are now thinking we need to revisit evaluation, look a little bit more at just functional, what's going on for this patient with this patient, this child, this adolescent, what's going on for this family, what's going on for this parent in terms of what are the impacts on their day-to-day function. So how is the child doing in school? How are they doing in terms of peers? What's happening in the home environment? What's happening with the family? What's happening with the community? But really focusing on major family and environmental stressors, also focusing on strength, and really covering, just getting a sense of how's it going for you and what are the biggest issues that you're concerned about right now. It allows for a much briefer assessment and then feeds nicely into developing, going through a top problem evaluation and developing a plan for what you're going to work on with the family or the youth and how you're going to support them. So it's very important to cover what's important, but step away from that detailed family history and clinical assessment that we have been doing for much of our career as mental health providers. So if we could go to the next slide. So I'm just really underscoring this issue of covering what's important, but stepping away from that detailed family history. And this is repetitive with the last slide, but I just want to take a moment to say that many times we pursue things that we think are important, but may not be important to the family at that point in time, or may not be important to the child at that point in time. And we really, I think, as we try to be more practical, hands-on kind of in the primary care setting, we need to be thinking about where can we step in to support, what kind of intervention can we share with the family to deal with the problem that they're presenting with, And if there's more complicated family issues, those are going to come back. They're going to come out over time. We don't need to get all that information immediately. So if we could go to the next slide. I talk a little bit about this youth top problems approach. So this was a way to assess kind of what you want to focus on in an intervention, with a focus on briefer interventions, by John Weiss and Bruce Charpita in 2011, and it's been tested and now is being used much more broadly. It's a psychometrically sound, client-guided approach that complements empirically derived standardized assessment. I'll show you a slide in a minute about how they've related that. So again, in the past, we may be doing much more in-depth standardized assessment to determine the functioning of a child. So for instance, some of you may have used the youth self-report form, or the child behavior checklist, or a complex checklist from a teacher or the school setting that gives you information across the board. This has been compared to those standardized assessments and seems to be yielding very similar kinds of data that can be equally informative in terms of treatment planning. So we're focusing the attention and treatment planning on the problems that the youth and caregiver consider most important. So as opposed to asking about everything and then coming back to making our own determination about where to start, with the top problems approach, you really ask the family, the youth, to identify what's most important to them. What are they most concerned about? What would they like to work on? Maybe just first, maybe there's other things over time that they want to work on, but how do you start care? And I think that it's really a critical piece of starting where parents and kids are at in terms of where we do our interventions. I think it's true across the board, but maybe particularly important in primary care, because we really want to build a partnership with them to be able to deal with things over time. If another problem emerges, if another issue surfaces, that we've built a relationship that says we're listening to them, we're working on the problems that are important to them, and we're not kind of focusing on other issues that we may have determined to be important, but are not pressing at that moment to the family. So then the top problems has also generated evidence on trajectories of change in those problems during treatment. And I'll show you a slide about that in a second. So if we could go to the next slide. It's a very simple approach, easy to use. You ask the patient, the family, the youth, depending on whether you're working with a parent and child together, whether you're working with a child on their own or a parent on their own who are trying to figure out how to move forward in their parenting practice or their parenting skills, to list problems that are most concerning in their own words. So as opposed to using a diagnostic label, what are you concerned about? What are the struggles that you're having right now? Obviously, you ask to make sure that if there's anything else that's not identified, that should also go on the list. So you don't want to limit them in what they're putting on the list. When the list is complete, you do a little bit of severity rating, and we do this very informally and quickly. How big of a problem is this? Kind of rate what you think are the biggest problems right now for you. And then which of these is giving you the most trouble? Which one is the most important to work on? And then that problem is identified as number one and the problem that you're going to be working on. So you may have a child who has potentially a number of problems that are, you may have a child with emerging ADHD. And right now, the parent's biggest concern is how do we increase this child's ability to get to school on time? And then we can come back to some of the other issues that are going to come up. So right now, we're going to really focus on what is the top problem. The top problem could be difficult. My child is having difficulties attending in school, and how are we going to address that? So let's go to the next slide. And this is just the first trial of looking, is a first is something we'll talk about in a minute. It's a common elements approach. And it's a treatment trial that looked at change in top problems compared to behavior problems checklists and clinical global and impression scores as a function of time. And the reason that we're showing that to you is just to say that the top, just to show you that the top problem, I think maybe I can do it with my pointer here, that the top problem, it really is very similar in its pattern of change over time and very similar in how what it measures as the behavior problems checklist, and the clinical global and impression score is a little bit lower across the board. So this would suggest to us that the top problems is hitting some of the same things that these longer, more time consuming, more difficult to score measurements have hit in the past. So let's go to the next slide. So now I'm going to switch gears. So we've talked about different ways of doing our assessment, different ways of figuring out what our treatment goal is going to be, our initial treatment goal is going to be. And then I want to talk a little bit about the use of common elements as a way to shape our intervention approaches. And common elements are predicated on the notion that most evidence-based treatment protocols can be subdivided into meaningful practice components. So as I mentioned before, many evidence-based treatment protocols have a 14 session, a 16 session, a 12 session protocol where you walk through a series of steps. People have kind of stepped back from that, realizing that that's a lot of intervention, certainly hard to do in a primary care setting. And it's a lot of training that's involved to learn those interventions. But there seem to be some common elements that are supported across interventions. So common elements are generic treatment components like exposure, like psychoeducation, like relaxation, that cut across distinct treatment protocols for common child and adolescent mental health problems. So we see these things applying to kids who are struggling with depressions, kids who are struggling with anxiety, kids who are struggling with trauma, as well as kids who are struggling with behavior disorders. So if we learn these common elements, we may be able to intervene effectively with a whole variety of kids in a more focused way. And they're very representative in all the well-established intervention protocols, such as cognitive behavioral therapy. So if we go to our next slide, why common elements? They're brief and they're learnable. So common elements are much easier than a dozen treatment protocols for intervention embedded in mental health interventionists to learn, and also much easier for primary care providers to learn pieces of to be able to use in their work. As we've already talked about, they address needs of a caseload and comorbidity, so you can use them across behavioral problems. You don't have to learn a specific intervention for each specific behavioral problem. They offer flexibility and flux because we all know that when kids and families present with problems, we may start out focusing on a particular problem, but then other problems may emerge, other problems may crop up, and we want to be able to pull in other skills and other approaches in a fluid and easy way. They are standalone elements and skills. So if we have a limited time with a family or a youth, and we can only, they're not going to stay in treatment for long, we only have 30 minutes on a particular day, we're not sure when we're going to see them again, we can teach and share, introduce one of these common approaches that can benefit the youth. And they're informed by practitioners and research feedback. So if we go to the next slide, if we just think about how do these common elements approaches fit into primary care? Just quickly. They're a good match to a wide range of age, gender, condition, and culture, and that has been studied pretty broadly. They have flexibility to be used in a way that's comfortable for a wide variety of problems and a wide variety of kids and families. There is emerging data that they have sufficient potency to be effective in brief interventions. And I think that's one of the things we all struggle with. We may need to be doing, as we do this mental health work, because of the high needs, the need to reach a lot of people, we may need to be doing briefer interventions, and we want to do something effective in that brief intervention. We can't always assume, and maybe it's not useful for us any longer to assume that we can do long-term therapy given the number of people in need. I think we've already talked about it. It's easy to explain and applicable across conditions, ages, and cultures, and it's easy for staff to learn and deliver with fidelity across the primary care setting. So if we go to the next slide, I think we feel like these kind of taking a common elements approach is a wise way to think about working in an integrated care setting. And I'm going to just present to you first, which is a common element approach developed by John Weiss and Sarah Kate Behrman. And just to give you a sense of what does this mean. So first, it's a principle guided approach. So you have specific, you're not looking for if you have a depressed kid, you have to do A, B, C, and D. If you have, these are things that you can bring to bear. If you have a depressed kid, if you have an anxious kid, if you have a kid who's anxious and also has some behavioral problems. So these are things that are transdiagnostic, can be pulled in. There's 5 core intervention principles that have demonstrated efficacy with this range, as a wide range of child behavior problems. And these, using these principles to design, you can use them to design individualized intervention to address the mixed bag of problems that most kids have. And so from across studies, they've been chosen across studies as effective strategies that have been associated with positive change. So if we go to the next slide, I'll just outline how they look in this first common elements approach. That's just one. And obviously you can see where first comes from. So F is feeling calm. So the kind of breathing, relaxation, distress management strategies that many of us have used in our mental health practices. So bringing to bear that cluster of skills that can be very helpful in a primary care setting. And an individual skill can be taught and practiced in a fairly short amount of time. The I is increasing motivation, and that is really what we think about in terms of depression, getting active, being motivated to try something different. Same for anxiety, being motivated and supported to try to do something that you're anxious about doing, but increasing motivation to give it a try. R is for repairing thoughts, and that is very simple, very watered down, if you will, but applicable in a primary care setting and in many, many settings to think about repairing thoughts. That cognitive restructuring that's been the backbone of CBT is something that can be a complex intervention to teach, particularly to adolescents. And this is just really introducing the notion that there is another way to think about a problem or conceptualize a problem that may allow you to move forward in a different way. Good old problem, S is good old problem solving skills, which many of us, I think, have incorporated into our interventions over the years. Again, can be steps that can be taught to kids and families to kind of manage the problems that they're struggling with. And then trying the opposite really is stands for working to do exposures. For anxiety, working to do exposures, trying for a depression, trying to get yourself out and get into a social setting, even when you're feeling like you don't want to do anything. And it applies for oppositional or behavioral problem kids. Trying the opposite also in those settings mean trying to move towards another up here without assuming that negative, that they're out to get you, that they're angry with you, that there's going to be a fight. So learning these 5 common elements, the strategies underlying these 5 common elements, gives you a whole bag of tricks that you can apply to a whole variety of problems in a primary care setting. So if we can go to the next slide, I think I'm getting close to passing back to you, Larry. So then the next slide is just to remind folks about the importance of making a really clear plan. And what I've outlined here is just an example. So you've identified anxiety about getting back into school as your top problems, what you might be saying to a parent, to a youth. You do some normalizing. It makes sense. You feel stressed about that. So many changes during COVID. It's hard to think about getting back into school. I know some strategies that might help you to feel more comfortable. Let's talk through one thing you could try. So for instance, maybe you teach box breathing for the student who gets very anxious and feels the urge to bolt out of class. Would you be willing to try that when you feel the urge to leave class? Okay. And how about if I reach out to you on Friday to see if that helped? And that might be a phone call. It might be a quick check-in with adolescents. It might be a text. And then you can continue to work together. So it's breaking down big problems into small steps to begin to move things forward in the primary care setting. And with that, I'm going to turn it back to you, Larry, to talk about some of the other big challenges that we're all facing.
Okay, I feel like we've thrown a ton of stuff at everybody. And so I think what I'm going to do, I'm going to talk, but I'm going to also watch the chat. And if there are questions that have come out of, especially I think what Elizabeth's been talking about, because that's really the stuff with the most immediate practical use, please put them in the chat. I can see it. And if stuff comes up, I'll break off and make sure that we have plenty of time to talk about those things. So the first thing I want to just cover is this question of social determinants of health, which has gotten a lot of discussion recently. So we can go to the next slide. So a question is really, what are the social determinants of health? And that there are many different definitions of them, but they are, in general thought to be things that, aren't mediated by germs or necessarily by, heritable conditions, but that have a strong influence on our well-being and on our risk of developing a variety of emotional and medical problems. And they can include both absolute or relative wealth or poverty, certainly food insecurity, our family or our household structure, social support or social isolation, our degree of education, our occupation, our experience of discrimination and structural racism, neighborhood conditions, both supportive and not, the social institutions that we're part of, exposures to violence. The list is long. Go to the next one. One way of looking at them, though, and this is from Ralph Moore, who's a community activist and organizer in Baltimore. I heard him give a talk once, and he referred to social determinants as the things that you can't CBT your way out of. Things like you live in a neighborhood that doesn't have adequate schools, or you can't get to work, or that you don't have a way to get around to the places you need to get to. You have chronically unstable housing, chronically unstable food. You are constantly living in a state of insecurity. You're constantly feeling subjected to a racism in one form or another. Next one. And just sort of as a reminder that our families are dealing with this is pre-COVID data put together by the Children's community benefits group. And it's really fairly sobering. This is data from the state looking at homeless youth students in Washington schools. So this probably doesn't include some of the highest risk kids who aren't in the schools to be able to answer the questions, but the sheer number of kids who are in Washington schools that identified as being unstably housed, basically doubled from the 2008 to 2018, and that number continues to go up. Next one. And if you look at this by race and ethnicity, we're closing in on 1 in 10 African American kids in Washington schools in 2018 reported being unstably housed, with high rates in Native American kids and Native Hawaiian and Pacific Islander kids. 1 in 20 of Hispanic and Latino kids. So really sobering numbers, and so we know that the folks that we take care of are experiencing these things. Next slide. This is just to sort of hammer this home. This is from a group that ranks U.S. counties by their essentially the social determinants and their influence on health. And just to point out that by their reckoning, if you look on the far right there, that contributions to sort of length of life and quality of life, about 50% of that, they feel comes from the social and economic factors that we live with, and 10% from our physical environment, 30% from our behaviors, and that clinical care has about a sort of 20% influence on this. So the thought, being that what we do is terribly important, but our ability to do that in the context of understanding these social determinants is really super important. So next slide. One of the big questions is, so how do we find out about these things? There are, any number of ways and many different, screening tools that people can use. The federal government sponsored something called the Accountable Health Communities trial, and they used this particular screening tool that asks just a few questions about housing. Do you have it? Do you not have it? Are you worried about it? Do you have concerns with its quality or safety? Do you currently worry about having enough food or a lack of it? Are there barriers that you have to getting to work, to healthcare and other activities? Have your utilities ever been shut off, or do you worry about it? You can go to the next one. Do you have concerns about interpersonal safety? How often are you or someone in your family, do you ever worry that you've been hurt by somebody or could be insulted or talked down to, threatened with harm, or screamed or cursed at? And that there are other tools. This is just one of them, but it gives you an idea of what the general scope of them are. Next one. So the question is, if we could try to address these, what would we try to get folks in touch with? So we talked at the beginning about this desire to try to have multi-generational care, even if we're in a pediatric setting. So for mental health, we want to try to connect people to substance abuse services, other community-based supports that might not be formal care, such as NAMI, CHAD, self-help interventions, child-adult service linkages. For employment, we might want to try to help people get parents or even some of our older patients get in touch with job counseling, supported employment, skills that help them to succeed in the work world, possibly even counseling or training that helps them to go into business for themselves, housing, certainly subsidies for rent or utilities or advocacy around those things. Next one. a huge need is for interface with the educational system, especially to speed up evaluations for learning or cognitive issues, getting the evaluations going that can potentially lead to kids having IEPs, tutoring if that needs to be done in the meantime, for both teens and parents, helping them to potentially get high school equivalency degrees that would allow them to progress in work or education, and just facilitating general interactions with the school system. This list, can go on and on. Next one. Another, big, challenge is the one that actually Elizabeth just talked about, of trying to figure out how to sort of sandwich these things into pediatric care. So let's go to the next slide. Actually, I think that slide was slightly out of place. So I'm going to flip back to the social determinants. One of the big, questions is that, oh, that's okay. You can go to the next one. That was, it's perfect. Thanks. Thanks so much. This is great. The biggest, problem with this social determinants work is saying that, wow, we can't necessarily do anything about these things, even if we get them out on the table. What's the we don't have money to hand out. We don't necessarily have ways of getting people access to these other services. So, this seems to violate in many cases this adage that you shouldn't screen for things if you can't do anything about it. And I think the case that I would like to make here is that it is really important to know about these things for a variety of reasons. I mean, one is because people actually appreciate the fact that we know that when we know all they're up against, then it gives us an opportunity to really appreciate their strengths. We often can help people problem solve in the short term. Sometimes, these things can seem overwhelming, and it can be helpful to people just to sort of talk and figure out, have someone helpful to talk with. Really importantly is that we can avoid advice that's impossible for people to carry out. Folks, for a variety of reasons, as you all know, will agree to things that they know they can't do, and we don't want to put them into that position. Another thing that Ralph taught me was that we don't want to we want to avoid medicating or therapizing things that aren't really amenable to that. Again, that ranges from just wasting people's time to actually potentially even being harmful. So if you go to the next slide, this is something that I feel like I tripped over many times, but it's just an example of how this social determinant stuff, being aware of it can help. Is I don't know how many times people have asked me for advice about how to help their child sleep, and you can approach this from a medical point of view and say, yes, well, you can take an antihistamine, it might make the child sleepy. You can take melatonin, you can take away their phone. We can help the family to do some sleep hygiene, but part of the problem with that is that then the family is left with still trying to sort of do this in whatever context they've got. And if we knew, for example, that this child's problem with sleeping happens because they actually don't have a consistent place to sleep every night, or because they sleep in a room with multiple other people, some of whom they might even be afraid of, we can then try to tailor our advice. We can do some shared problem solving with the parent about how best to support the child sleeping. We might even be able to help them get a sleep kit for the child that helps them to feel that there is some continuity among the different places that they sleep. And certainly we could hook them up to some services for other places. Okay, so I'm gonna just try to wrap up this part. And then I think we'll try to really leave things open for questions. So next slide, please. I want to just make a pitch for us thinking about how we can help parents. So this is another one of those meta-analysis studies. And what it did is it looked at depression treatment programs for women who happened to be mothers at the time. And it looked at the outcome for the children when the mothers received psychotherapy. And again, the bottom line here is all these funny shapes are to the right of that vertical line that says 0, which means that when you put this stuff together, treating parents was good for their kids. So it's worth it to us as pediatric providers to be able to be aware when at least children's mothers have problems with low mood and try to figure out how we can help those mothers get care. Next one. Elizabeth, this is you.
Quickly,
Yeah.
just we talked a little bit about the changes that people are considering in terms of mental health interventions and how that might help us better do our work in a primary care setting. And I just have a couple slides that give some examples of that I think that we frequently mental health folks are kind of trained to do long-term kind of supportive interventions. And there's been a new kind of challenge, I would say, to say, what can we do to affect change that would be useful, might not get us a home run in terms of all the things we'd like to address, but would help a family or a child move forward in a productive way. And one of the things that people are talking about and studying are something called minimal interventions needed for change. So low complexity, cost-effective, evidence-based approaches that are defined as the lowest level of intervention intensity, expertise, and resources needed to achieve clinically significant improvement in a specified outcome. I think that integrating these kinds of approaches or this mindset, maybe more importantly, than these aren't specific approaches necessarily, is highly compatible with work in the primary care setting. Because again, most of these approaches are taking some key common elements, so that they can be learned in a brief, flexible, and accessible manner so that more people can use them. And just one example of MINC is measurement-based care. And we talked about that at the early on. Larry talked about it, I mentioned it, the importance of using some assessment to identify who's in need, where they are at as they enter care, and then how do they change over time. And then if we look at the next slide, and I don't think we're gonna go through, I just wanna also introduce another thought, and that is we are obviously in the time of the internet and the time of a lot of multimedia ways to support the work that we can do. And there is some growing support for the usefulness of a single session kind of therapy. I'm going to talk about, Larry, I think is going to talk if there's time about some single session work that's been done. But I just wanted to introduce the notion that there's a emerging group of single session kinds of approaches that are online supports for kids and families. Jessica Schleider, who's a psychologist at Stony Brook, has developed a number of interesting kinds of interventions that a parent can go to online or youth can use online to modify features. For example, features of depression. There's something called Project Personality, which targets hopelessness. There's she said her project. So it's the ABC project, which targets engagement and meaningful activities to combat anhedonia, kind of a behavioral activation strategies. Project Care, which targets self-compassion to combat self-hatred. And then she also has a web-based support system for parents. Again, these are one-shot brief interventions for parents to support their reductions in making accommodations for their anxious kids, because we all know that when your child is highly distressed, your kind of first impulse is to want to let them off the hook, help them, support them in any way you can, when we know with anxiety that probably what we want to do is encourage them to try something that may be hard. So just to give you a little tip my hat to the fact that there's some really interesting emerging strategies that can help us do work in primary care. I'm seeing a question, and I think it's a really important one. So I think it may be time to go to that, or you've got some other slides there, Larry, that you might want to talk about. I don't know.
Oh, I think this is a great question. I guess one thought I have is, Tim, can you unmute, and do you want to just say it, especially just in case there are people who are on the phone? If not, I can read it.
I'm working to see if I can unmute him.
Okay.
Sorry, one moment. Tim, are you able to speak now? Zoom likes to make things extra difficult on these, so.
Okay, he says he's unmuted now, so.
Great.
He is unmuted.
Well, I mean, Tim, just if you do want to speak, but in the interest of time, I'll paraphrase this. I think most people can probably see it. So this is the dissonance between the idea of doing short-term, very problem-focused interventions versus not having and potentially missing the opportunity to really understand. So I think that it's clearly a tension, and I think that a potential answer to it comes in two ways. So one is that hopefully some of this short-term work is happening in the context of a continuity relationship in primary care, and there is some hope that a lot of that other information is sort of known to the primary care provider. A second piece is, well, what do we want to start doing as a routine part of our visits to try to get some of that contextual work? And there's a piece of that which probably does come from, screening, or whether you want to call it screening, and some regular asking about some of these particular issues that we'll call them Ralph's issues for the moment. But the second is how one has an interviewing technique that combines this top problem approach with an open-ended way of saying to people, what's happening now, what are your main concerns, how can I understand the context of this problem that you're sort of putting in front of me. So that's, I could talk longer about it, but I see the tension, so the hope is that there are other ways to get the context rather than in our typical sort of longer view. I guess the third piece is that it is checking back in, as Elizabeth said, is that we don't give this information just as a one-shot thing, but we then check in and say, well, what happened? And if it's not working, then we can understand why. Anyway, Elizabeth, do you have another answer to that?
Well, I would just add to that. I totally feel like you've hit the major dilemma, the major tension, as Larry said, on the head. And I think the difficulty is typically in a primary care setting, you have a very limited amount of time. And so you're needing to both be validating of the complexity of the individual family and individual kid's life and situation. And again, I think that you're hopefully have some more of that background information without having to ask every single question. You're not just garnering all the initial information because this child is already in the practice and there is some information available. But I think that it's that balancing act between going there, and it's something that you're doing in the work that you are already doing, and offering something that helps, that seems to be a step forward or a way to begin to tackle what might seem to be a tiny little piece of the dilemma that the family or the child is. And so I feel like the top problems, part of it is how do we pull out of the complexity of their situation a little piece of a problem that they can begin to take some begin to address and help them begin to feel some mastery, some sense of, I'm not gonna, we may connect you to a care manager or to a housing program to help you with some of these broader things, but let's take a little bit of time right now to talk about some strategies to increase your motivation to attend school. And so you have to be acknowledging the reality of their situation, while also I would say this strategy helps you bite off a little bit to begin to work on in a more concrete fashion. And I think that the goal would be to give some hope and some sense of empowerment, that even in the face of these big daunting issues, that you can get some support to get yourself into a somewhat better situation.
So Larry and Elizabeth, it looks like we have maybe time for 2 more questions. So the first one.
About how do you decide when to move into mental health? Oh, did Anna freeze? Looks like maybe she froze. But we're not frozen, so we'll answer. Anyway, I think the question about how do you decide about when to move from primary care to the next. So some of that depends on what you have set up in primary care, but usually what that would be is, I think, saying, okay, within primary care, I'm set up to try to do some of these brief transdiagnostic interventions, possibly in combination with some first line medication if one is indicated and the primary care folks feel comfortable delivering it, and saying, okay, we have some criteria. We're going to do potentially 5 or 6 sessions maybe, and at the end of that time, if the family feels that it's not making that the child's not making sufficient progress, if some of the original treatment goals haven't been met, that would be the indication for then trying to move to a higher level setting.
So I've done something to my system so I can't actually read the chat. So I may be off target here. I feel like there's a question about how much time do you spend? And I think that in most primary care settings, I'm not speaking about the primary care provider themselves, but the embedded mental health person. From what I'm understanding from folks is they typically have about 30 minutes. So they really are, you're challenged to figure out how you make a connection, listen to what's going on, and then try to give some kind of strategy that can connect with the person and give them something to increase their hope and their sense of motivation and power to tackle the problem. And it may be initially you're just really watching, asking them to monitor what's going on to see what would be more helpful. But I think that typically what I've heard from embedded folks, they have about 15 minutes to 30 minutes. And then the other thing I would say is in the subsequent presentations in this series, folks are going to present some much more concrete examples of mental health intervention strategies and things you can pull on, and examples and ways to use them.
Well, this is Sarah Walker. I'm just going to jump in because it's just a little unclear. Oh, Anna's back. Hey, Anna.
Hi, everyone. Sorry, Zoom kicked me out at possibly the worst time. But just noting the time that it is 2:30, we're just going to wrap things up. So thank you so much for being here. And thank you so much to Larry and Elizabeth for this wonderful and rich presentation. And we hope you'll all join us next week for part 2 of the series at the same time, and on December 3rd for our 3rd installment. And again, feel free to reach out to us. I know that there may have been more questions that we ran out of time for, so feel free to email us at uwcolab@gmail.com if you have additional questions. And we can also share Larry and Elizabeth's contact information as well. And thank you again for being here. And don't forget to register for CME credit if that is part of your attendance for this webinar. All right, thank you so much, everyone.
Yeah, thank you all. Just,
Okay.
this is to begin. Conversation to begin.